Hi everyone. I bring greetings from Mohit Bariatrics and Robotic Surgery Center from Indore, India. I welcome you all to yet again another episode of Virtual Bariatric University. Today's topic of discussion is one anastomosis gastric bypass or a mini gastric bypass. So one anastomosis gastric bypass is a very contentious procedure. The procedure was devised by Dr. Robert Rutledge in 1987 after he serendipitously assumed that a procedure he used for treating a gunshot wound actually treated the obesity and diabetes of the patient. After that, there was no looking back. Many surgeons from across the world who trained under Professor Rutledge started performing the procedure. We all began our journey in mini gastric bypass in 2011 after Dr. Bhandari met Professor Rutledge. The procedure sparked great controversy due to its effects like suspicion of high incidence of marginal ulcers, bile reflux, excessive weight loss, and most people considered it as a glorified version of loop gastrojejunal anastomosis, which was abandoned long back like Bill Roth 1 and 2 operations. So OAGB MGB has come of age with humongous data in favor of the procedure, many valued publications, so much so that today many regard one anastomosis gastric bypass as the future of gastric bypass operation. Nevertheless, we are all here today with a stellar group of very knowledgeable faculty to guide us in the light of present-day evidence. I'm so honored to welcome none other than the President-elect of IFSO and Editor-in-Chief of Obesity Surgery, Dr. Scott Shikora. Dr. Scott Shikora is the Director of the Center of Metabolic and Bariatric Surgery at Brigham and Women's Hospital and Professor of Surgery at the Harvard Medical School. He is both a past president and a former executive council member of the American Society of Metabolic Surgery, and is also an associate editor of the Sword. And he is currently the editor-in-chief of Obesity Surgery. I welcome Dr. Scott Shikora. We also have with us our past president of IFSO and one of the most gifted bariatric surgeons of the world, a true leader, Dr. Almino Ramos. Dr. Ramos is a world-renowned bariatric surgeon from Brazil. He is the Director General at the Clínica Gastro-Obeso Center. He is the past president of the Brazilian Society of Bariatric and Metabolic Surgery. He is now on the board of trustees for the IFSO. I welcome Dr. Ramos. To add more to this evening, we have Professor Roslin from New York, who has extensively published on relevance of limb length, which could affect the outcome in the procedure we are discussing today. He is the Chief of Obesity Surgery at Lenox Hill Hospital in New York City. He is also the president of the Manhattan Minimally Invasive and Bariatric Surgery. He is the founding president of the NYS FASMBS and co-chair of the Access Committee of ASMBS. I welcome Dr. Roslin. we have our own Dr. Arun Prasad, the past president of OSSI and one of the early beginners of mini gastric bypass in India, who championed a large series of this procedure. He is the senior consultant in General GI and Bariatric Surgeon Department at Indraprastha Apollo Hospitals, New Delhi. He is also the past president of the International MGB-OAGB Club. He is the founder member of the BRICS Bariatric Surgery Society. I welcome Dr. Arun Prasad. Last but not the least, we have with us Dr. Patrick Noel from both France and U.A.E, a leader who has extensively published on sleeve revisions and has a strong opinion on implications of mini gastric bypass. He has been actively involved in the activities of French and international surgical societies, including the FASMBS, the IFSO, and is a reviewer for SWORD and obesity surgery. Now he has joined several renowned hospitals across the Gulf region for training young budding surgeons to minimally invasive and robotic surgery. I welcome Dr. Patrick Noel. And Dr. Fobi and Dr. Bhandari are the co-directors of the course. So without much delay, let me invite the moderators for the first session, Dr. Almino Ramos and Dr. Roslin Michel. Guys, the forum is yours. Thank you.
Thank you. Good morning, and thank you for having me here. Almino, it's a pleasure to share the podium with you. I guess I have the honor of introducing somebody that really requires no introduction, Dr. Mathias Fobi. Few people in bariatric surgery have an operation named after themselves, like the Fobi pouch, an operation that he popularized when he was in California and treated some of the most famous people in the world when bariatric surgery was really just increasing in popularity. Dr. Fobi has been a true pioneer in bariatric surgery, and as his career progressed, he decided to move over to India and work with Mohit, and has become a big proponent of, instead of a strong restrictive operation, to the one anastomosis gastric bypass. So I think it's absolutely fascinating to hear the story of kind of how he has viewed things differently, and it demonstrates his willingness for knowledge and learning, that somebody who had an operation named after them will speak about some different concepts. So without further talk, I'm really proud to introduce my dear friend and one of the most famous bariatric surgeons in the entire world, who keeps giving to this field, Dr. Mathias Fobi.
Thank you, thank you, thank you. Let me share my screen. Thank you very much for that kind introduction. I'm talking to you remotely from Atlanta since the COVID came, but I'm still working closely with Dr. Mohit Bhandari in Indore at the Mohawk Bariatric and Robotic Surgery Center. I bring you greetings from Indore, same university where Mohit and I are clinical professors. And on the left-hand side there, you see where we do most of our research and do have laboratories for laser surgery and everything else. And then Mohawk is down there. My own disclosures are few. I'm the founding president of Bariatric, and I personally had a gastric bypass to treat morbid obesity and also to treat my type 2 diabetes. Now I'm not advancing, okay. Before I came to India, I had started doing bariatric surgery in 1974 through 2014 when I retired in the States. And I did mostly gastric bypass, about 3,000 plus banded gastric bypass and about 2,000 regular gastric bypass. And before that, I did a lot of gastroplasty, VBG, and SR-VBG. However, since I've been in Indore for the last 4 years, I do about 30% gastric bypass, 30% banded sleeve, and 30% banded one anastomosis gastric bypass. I'm talking about OAGB. That's a word that is new to me, but I have to adapt it because everybody else has adapted it. However, I want to make it clear that OAGB to me means a particular operation that was described by Caballeros and Cabajo. It is a robust operation that has a consistency of having a biliopancreatic limb of 60% and a common limb of 40%. However, the surgery I'm going to be talking about has now been accepted as the OAGB MGB, but I prefer to call it the MGB-OAGB. That way we don't make any mistakes as to what we talk about. I'm talking about the Routledge procedure, which he described with a fixed biliopancreatic limb or variable biliopancreatic limb of 150 to 150 centimeters. And so that is what I'm going to talk about today. The MGB is a loop gastric bypass fashioned after the Mason gastric bypass. It consists of a pouch which runs anywhere from 13 to 18 centimeter pouch, depending on the height of the patient. The diameter of the pouch is about 2 to 2.5 centimeters with an afferent limb 150 to 250 centimeters. My experience changed with the MGB after I came to the United States. I came to India. Before that, the perception in the United States is that the MGB was a procedure that had high complication rates with reflux gastritis, protein malnutrition, and a tendency for Barrett esophagitis. I had done some MGBs, but I stopped doing it based on that. However, when I came to India and I got a chance to be exposed to the procedure, my opinion changed, and I've been doing that procedure since. My timing on my slide is a bit different from what I like, but can you advance the slide for me? Okay. Because a group of doctors got together and reviewed operations that they had done, revising the procedure that Routledge performed, they wrote a paper about a review paper on the one anastomosis, or what was called the mini gastric bypass, and came to the conclusion that it was not a good operation. They did a detailed review. At the end of their review, they made some recommendations, either to stop doing the procedure, to do a prospective study, or everybody who does the procedure should have to put it in a registry. Unfortunately, they decided that it was a bad operation and condemned the procedure and the innovator. Fortunately, this procedure had started being done in Europe and in Asia, and so there was reincarnation of the procedure in Europe when Cabajo and Caballero decided to do what was called an omega loop gastric, one anastomosis gastric bypass. So the compromise name became MGB-OAGB. And so a lot of these procedures were done in Europe and in Asia. I got introduced to the MGB-OAGB by Dr. Kular when I went to a meeting in Mumbai, India in 2011. And I had a chance to debate Dr. Wei Jei Lee in 2012 or 13 in Istanbul. And I had a chance to visit with him in Taipei and observe the MGB performed live. Unfortunately, or fortunately for me, I was so impressed with the outcome, looking at his statistics, and the outcome from Dr. Bhandari's work, that I had to start doing the gastric. Gentlemen, I'm really getting a lot of interruption. The lawnmower outside my house just started mowing, and my granddaughter just walked in. Just give me a minute. Let me see what I can handle. Yeah. Now, I'm on the phone and the lady is here. Tell the person from the place that it's not mowing. Jesus Christ. Sorry. Well, I had tried to tape this talk so it could be presented because working from home is difficult. My granddaughter is here and the lawnmower people are outside, so I had to shut up everything. Let me try to catch up with you. I joined Mohawk in 2017 and I started doing a lot of MGBs with Dr. Bhandari. He does about 100 cases a month and about 50% of those are MGB operations. So I had an exposure to it. So at indoor, the cases about 30% gastric bypass, 30% MGB, and 30% sleeve. We do occasionally non-banded procedures, and occasionally we do the ESG. In addition to running the CME courses and the fellowship program at Mohawk, I had the responsibility to analyze the data that has been prospectively maintained and we have about 7,000 cases that I looked at. Of these, 2,796 were MGB-OAGB patients, and some of them had up to 7 years follow-up. So we reviewed this data, and now I looked at the data and I came up with a different impression about this operation. As you can see here, just for weight loss, we looked at the MGB versus the banded gastric bypass, the procedure I used to do, and the regular gastric bypass. And the 4-year results showed definite better weight loss with the MGB than with the banded gastric bypass and the regular gastric bypass. There have been a few leaks, but not intractable leaks like in the sleeve gastrectomy. The most common problem with the MGB is staple line bleeding. You have 2 long staple lines. With good patient selection, there is low incidence of gastroesophageal bile reflux, protein malnutrition, marginal ulcers, and most of this can be treated non-operatively. The incidence of food intolerance is similar in all 3 procedures. With a BP limb less than 200 centimeters in length, the incidence of diarrhea is low and comparable to that of SADI and BPDS. Next slide. As you can see from this diagram, the hemoglobin and level is reduced in all 3 operations, just slightly more in the MGB. Similarly, the albumin and protein levels are reduced slightly. Again, just slightly more with the MGB, but not significantly more. And the calcium level is similarly reduced. But as you can see, it's a difference between 8.7 versus 8.3. With these findings, I came up with the impression that the MGB is a robust bariatric metabolic procedure that should belong in the armamentarium of all bariatric surgeons. It should be used selectively in patients. Patients with this operation need closer monitoring than patients with the regular gastric bypass. I would like to remind all of you that there's no one operation that fits the needs of all patients. A competent bariatric surgeon should be able to adequately perform a variety of bariatric procedures, which includes sleeve gastrectomy, banded sleeve gastrectomy, gastric bypass, banded gastric bypass, MGB, and banded MGB. And where they are trained, they can do the endoscopic sleeve gastroplasty. At Mohawk, at this time, we instituted a routine pre-operative and post-operative. Okay. We have an established protocol and an algorithm to choose the most suitable operation for our patients based on currently available medical evidence. We have an ongoing clinical trial of all the patients who have MGB at our center, and we enter our data prospectively in the OSSI dendrite registry. The MGB, we have contraindications to this procedure. Patients who have liver disease, peptic ulcer disease, GERD, hiatal hernia, inflammatory bowel disease, class 1 and 2 obesity, heavy smokers, and patients not likely to return for follow-up, we don't offer them the MGB. I think people have problems with the MGBB because they do it on every and all patients. We find that making this relative contraindication and offering patients with these pathologies other operation minimizes the incidence of problems. It is a fantastic operation for about 30% of our patients. It's good for patients with superobesity because it gives better weight loss. It's excellent for patients with type 2 diabetes and long-term history of diabetes because it produces better resolution than the regular gastric bypass and the sleeve. It's good for high-risk patients because of the short time of the procedure. It's usually done in less than 40 minutes in our center. And in patients with class 2 and superobesity with no GERD, hiatal hernia, and liver disease, they also do well. And older patients do very well with this procedure. We do the sleeve gastrectomy in young patients, patients with no diabetes, patients with alcohol abuse history, patients with peptic ulcer disease, cirrhosis, smokers, chronic anemia, gastric cancer endemic areas, and young childbearing females. So we do have an algorithm that we follow, and I think that is why if you do the MGB selectively, you don't have as many problems. The gastric bypass, on the other hand, we use it in patients with type 2 diabetes with hemoglobin A1C less than 8 and a short duration of diabetes, patients with GERD, patients with hiatal hernia, very strict vegetarians, and patients who have NASH or mild liver disease during the operation. We do endoscopic sleeve gastroplasty in patients who do not want laparoscopic surgery and patients who have a BMI between 27 and 35. These are the factors that affect or determine the choice of the operation we do at Mohawk: the gender, the BMI, type 2 diabetes, GERD, vegetarianism, meat eaters, ability to afford supplements, ability to have regular follow-up, peptic ulcer endemic areas, gastric cancer endemic areas, obesity, mortality risk scores, the expert of the surgeon. A flower does not think of competing with the flower next to it, it just blooms. So the MGB is just another flower that blooms, and we should use it. I would like to thank the staff at Mohawk, with whom I've worked for the last 4 years, and I would like to thank the Bhandari family for giving me the opportunity to work with them. Thank you very much. Go ahead.
Almino?
Turn it to the moderator, please.
Yeah.
Almino, you want to go and ask?
Yes. Thanks, Mitchell. It's my pleasure to participate in this VBU. I think this is a very nice idea, and I want to congratulate Mohit and Mao and Winnie for this action, and of course Scott, Patrick, and you, Mitchell, for working together in this morning in this session. Very nice presentation, Mao, and I wanna discuss with you 2 points. The first one is we know that in the past, as you said, you had a gastric bypass, and that's was in the time you didn't know about the one anastomosis gastric bypass. So if you have the chance to go back, would you change your option for a mini gastric bypass right now? And the second, Mao, is I have been discussing this technique with different surgeons, and the seniors, as you, they demonstrate a lot of, they are not comfortable with the issue of carcinogenesis of this operation. That in the past we had a lot of Bureau 2 reconstruction gastrectomies that in the evolution 20 or 30 years after the patient presented a gastric cancer. So let me know your thoughts about these two issues regarding one anastomosis gastric bypass.
Yes, my answer will be very brief and to the point. I had a banded gastric bypass, which at the time when I had it was what I thought was the best procedure done on me by Dr. Kelvin Higa. But with what I know now, at the age, I had that surgery at the age of 65. So with what I know now, I would have preferably had the one anastomosis gastric bypass. And I would probably have used Dr. Mohit Bhandari because he will do the procedure in 30 to 40 minutes. My anesthesia time will be less. And I will have better eating, quality of eating. Right now, those of you who've gone out to dinner with me know I eat the hors d'oeuvres and I quit because I cannot eat anymore. It is very successful. I've kept the weight loss off and my hemoglobin A1C level is good. But again, I could enjoy a little bit of meal if I had the MGB. So that would answer the question. The second part of it is, oh boy, I've got
carcinogenesis.
Oh, yes.
About carcinogenesis.
Well, that is why we have the algorithm. There is not enough information to make that implication. We do have increased carcinogenesis with the sleeve and with the gastric bypass. I personally have 5 patients who've come down with colon cancer after gastric bypass. And I think that might have something to do with it. And I've seen patients with the sleeve who have Barrett's, and some of them have some metaplastic changes. And we're not worried about that. We have been looking at an MGB and we do not have that. But in the meantime, we are surgeons and we should be able to make decisions. So if there's something we're worried about, we should collect data, put our data in the registry. In the meantime, avoid what might cause patients to have esophagitis. So you select patients who do not have GERD or findings of esophagitis preoperatively, and don't give them the MGB, so you minimize it. Number 2, if you're worried about it, select patients who are 45 years and older. Most of them are going to live for about 30 years, and therefore, by the time they get the cancer, they'll be dead. So try not to do it in young people. We have an armamentarium of procedures, and that should allow us as surgeons to choose procedures and collect the data. We cannot deprive people of a very good operation because we are worried about what is going to happen 30 years from today. So instead of doing that, I have this algorithm that Dr. Mohit and I have developed. We try not to do the MGB on patients who are young. We try not to do it on patients who have GERD, hiatal hernia, GERD either symptomatic or on endoscopic findings. Thank you.
Thank you.
Mal, so I'm curious, and I guess there are 2 questions that two points that come to mind. One is, it's interesting, if I looked at the algorithm correctly, you guys prefer a banded gastric bypass for people who have GERD symptoms. Now that may prevent some bile reflux because it's a Roux-en-Y, but it would seem that you're putting a band distal to the hiatus, which could certainly, certainly encourage some reflux from the pouch symptoms. So I'm curious to why you think that that is a better alternative for GERD as opposed to the mini gastric bypass where potentially bile is absorbed. And I think we all agree that we need a procedure that's more robust than sleeve as BMIs increase and diabetes gets worse. How would you contrast the one anastomosis gastric bypass to putting the anastomosis beneath the pylorus, or what a lot of people around the world are beginning to tout, the SASI type alternative, which also has not, come to the United States?
Well, you have 2 questions in one. First, the banded gastric bypass and reflux. Let me point out, I have looked at the data we have more than 20,000 patients who've had the banded gastric bypass, at least documented in the literature. One of the things I've not seen with the banded gastric bypass is I've not had cases, and Dr. Almino, correct me, because there are more banded gastric bypass that were done in Brazil than the rest of the world, because at one point I was the only operation done in Brazil. I have not seen cases of megaesophagus like we used to see with the adjustable band. And we don't have any instance of anybody dying from that or anybody having excessive reflux from that. That has not been reported. There are complaints of regurgitation, which is food intolerance because of the ring, but not an increase in reflux. Now, when you start talking about the treatment of reflux, it is the gastric bypass in relatively small pouch in the gastric bypass, banded or not, that minimizes the reflux as opposed to the MGB. In the MGB so far, with our preliminary findings, we endoscope patients after bariatric surgery. In the one anastomosis bypass patients, we see bile in the stomach in about 30% of the patients. And bile that goes to the esophagus is about 3%. So those are objective findings we have. So you're going to have bile in the stomach, but whether it refluxes into the esophagus, I believe, and I feel strongly that it is in patients who have dysfunctional lower esophageal sphincter. People don't want to look at the past, but that's what we knew. Reflux was a problem of the sphincter. It was not a problem of the hiatus, it was a problem of the sphincter. So if you have bile in the stomach and you have a competent sphincter, you're not going to have bile reflux into the esophagus. The comparison between the one anastomosis gastric bypass and the duodenal jejunal bypass, there's to me no difference, except the possibility of there not being less bile. But again, I looked at the surgeries. We had a long seminar this weekend from around the world, and I had the privilege to see 3 duodenal jejunal anastomosis made. And I came to the conclusion that what is done and what is said are 2 different things. All the doctors who did the duodenal jejunal anastomosis did it at the pylorus. The pylorus was involved in the anastomosis. And if you have a chance, when those films come out, go and look at it. So that pylorus in the duodenal jejunal bypass does not function as a restrictive mechanism. Except somebody can do a study and show me by contrast that there's no reflux, I'm not going to buy it. But I looked at competent surgeons who did an excellent operation and did a duodenojejunal anastomosis with the loop SADI procedure, and I bet you they will have the same amount of bile going back into the stomach because that pylorus was not functional. But I'll leave that up to Ross, those of you doing the procedure, to look at it. Thank you.
A great presentation, Dr. Fobi. Thank you so much. Your academic sagacity in the field of bariatric surgery has transformed lives of many surgeons across the globe. So thank you so much for the presentation. Now let me invite the second session moderators, Dr. Arun Prasad and Dr. Patrick Noel.
Thank you very much for your kind invitation to participate to this great idea of virtual conference, and especially during this time of COVID-19. And it's a great pleasure for me to meet some friends like Mohit, Mal, Almino, and others. I will introduce Dr. Shikora, but you did already the job. We no longer present Scott. Everyone knows him. He was promoted to Professor of Surgery at Tufts University School of Medicine in 2005. Then he joined the Department of Surgery at Brigham and Women's Hospital as Director of the Center for Metabolic and Bariatric Surgery, and as well as Professor of Surgery at Harvard Medical School. He has numerous awards and they include the Distinguished Achievement Award of the FASMBS Foundation and the President's Award of the IFSO. He has served as President of the FASMBS. He is currently President-elect of IFSO, and as you mentioned before, is Editor-in-Chief of Obesity Surgery. So he will explain us the current U.S. experience with anastomosis gastric mini bypass. Dr. Shikora.
Thank you very much for the invitation. I'd like to thank Mohit and Mal for inviting me, Winnie for all what you do behind the scene. It's an honor for me to be part of such a reputable group of world-famous surgeons. I'm going to fill you in on what's been going on in the United States, and I'm going to also give you some historical background because that's why we are where we are today, so different than the rest of the world. Here are my disclosures. None of them have any bearing on this presentation. I want to also add a disclosure. I've never done a primary one anastomosis gastric bypass, but I've done several as a revision for sleeve. I'm also more favorable for that operation than most Americans and would like to see it in the United States in part of our armamentarium. I'm preaching to the audience here and to say that the mini or one anastomosis gastric bypass achieves similar, if not better, weight loss and metabolic benefits than the Roux gastric bypass, because you all know that already. And it's well regarded around the world, and you know that already. Yet the ASMBS, the American Society of Metabolic and Bariatric Surgery, still doesn't endorse it. Few surgeons in the United States are interested in it, and almost no patients, even those that are internet savvy and know about it, come forward and ask for it. Why is that? Well, as Winnie brought up earlier, the original operation was the mini gastric bypass developed by Robert Rutledge when he was in North Carolina in the United States. So this operation was actually born in America in 1997. And he came up with the concept of the long, narrow pouch and the single anastomosis and an afferent or a biliopancreatic limb of somewhere around 200 centimeters. And we know the world data. This is the meta-analysis done by Chetan Parmar, a colleague of ours, demonstrating, looking at almost 13,000 patients in the literature and finding great improvement in the comorbid conditions, particularly type 2 diabetes, as well as very, very good-looking weight loss of almost 80% of excess weight out as far as 5 years. We also know that the operation has gone head-to-head with the Roux-Y gastric bypass and performed quite well. This study by Wei Jei Lee, looking at about 1,100 one anastomosis bypasses compared to almost 500 Roux. And no surprise if you put an operation that you had to do 2 anastomoses compared to an operation that you only had to do 1, the OR time for the one anastomosis was less, significantly less. Complication rate was lower because you removed an area of complications, which was the jejunal and a lower revision rate. Interesting, though, Dr. Lee brought out that with the Roux-Y gastric bypass, there was a higher incidence of mechanical issues such as internal hernias, small bowel obstructions, and with the one anastomosis, it tended to be the bile reflux, which we'll speak more about in a moment, and nutritional issues. So if you came to me and said, you have a simpler operation than what I'm currently doing with less complications, shorter learning curve, easy to reverse if need be, great weight loss, excellent control of comorbids, I would say you have the perfect operation. Well, I just described the one anastomosis gastric bypass, and as many people around the world believe, it's the perfect operation. So what's going on in the United States? As I mentioned, FASMBS does not endorse it. It's not accepted by surgeons, by health insurance, by the government, or by patients. Isn't that something? This perfect operation is being looked upon so poorly in the largest country that does bariatric surgery. So let's dig down a little into what's going on here. Well, it comes down to about 4 facts. And these facts are indisputable. Number 1, there's a lack of reliable American data. We have no studies, and it's a bit of a vicious cycle. If we don't do the cases, we can't get the data. If we don't have the data, we can't do the cases. The concern about bile reflux esophagitis continues. And let's be honest here, it's political. The inventor's contentious relationship with the FASMBS and American bariatric surgeons certainly has not helped, where there's a dislike and a disconnect between that person and the American surgeons. And the need for having a conservative approach. Eric DiMaria brought this up at the IFSO meeting, and it's really important. Because America was the starting place for a lot of the bariatric surgery, we have seen come and go, and Dr. Fobi could, back me up on this, many operations that turned out to be losers. I put a couple of pictures up and look at the mesh wrapping of the stomach. That was a horrible operation. So in America, we need to take a very conservative stand because we've had so many of these bad operations come and go that it nearly cost us our field, where malpractice insurance companies wouldn't cover our surgeons and health insurance companies were not going to pay for the procedures. We had a real problem before the centers of excellence came along, because of the fact that we allowed so many untested, poorly developed operations to make it to the big time. So that's pushed this back into a more conservative mode. Now, in the United States, this was the original paper that Dr. Rutledge wrote about almost 1,300 patients, and this study was not believed by the American surgeons. One, because there was an online computer tracking of patient outcomes. There was no patient clinic visits. They were not seen in person. It was all internet. The results also just seem to be too good to be true. A half-hour operation, a day and a half in the hospital at a time where patients generally stayed in 3 or 4 days, and an incredibly low complication rates, the bile reflux of 0.47%, only a 1% risk of leaks, small risk of marginal ulcers, and 1 death in 1,200 patients. The surgeons in the United States said that's not believable data, and there was no way to back it up because patients were not being seen at the center where the surgeries were done. And then this came up. This was, I think Dr. Fobi also showed this study. This was Eric D. Maria's group. They were at a hospital near where Dr. Rutledge practiced in North Carolina. And they quizzed all the hospitals within, I think it was a 50 or 100-mile radius around the center where Dr. Rutledge was. And they came up with 32 cases that required revision, mainly for severe bile reflux, some for malnutrition and other reasons, at a time when Rutledge reported it was only 6 cases that he did. So here's 32 cases that never made his paper. Now, Eric looked at the data again recently, so 10 years later, and he reported this last week at the Clinical Congress, that they found another 30 cases of patients in that area that required revision because of bile reflux. So that's why the Americans looked at that paper and said, we don't believe it. What are the concerns? As you all know, it's the afferent loop syndrome, it's the potential for malnutrition, and I would be concerned about the vegetarians who have any form of malabsorptive procedure. Leaks could be more deadly than a roux leak because in a roux leak, it's usually saliva. With this leak, it's bile and it's pancreatic enzymes. So it could be more dangerous. We heard about the marginal ulcers, but it comes down to the bile reflux esophagitis debate that I think will make or break whether this operation is approved. Now, I'm not going to go through the whole thing about esophageal cancer. We can fight that any time we want. But the animal studies have suggested that if you have a loop reconstruction, no matter how you do it, you end up with a risk of esophagitis, Barrett's esophagitis, and cancer, where the roux limb essentially never sees that, at least in the animal model. And Dr. Fobi mentioned this as well. When this was all going on, the bariatric community in the United States got together and wrote an editorial in obesity surgery of their concern about the operation. And look at the people who signed this letter. These were the thought leaders, the most important people in our society. And they were coming out and saying, we don't trust this operation, at least not now. And what about the US data? Unless I'm mistaken, and I've looked, I couldn't find any other papers about studies done in the United States. And there are very few surgeons doing the operation. Cesar Paraglia is one of them. He's in Florida. He does essentially a private practice business because insurance doesn't cover it. And this was a paper he wrote a few years ago about patients over the age of 60. So it's not even a review of his whole database. But this is it. There's no other data in America for us to take to insurance or to take to FASMBS to use to demonstrate the operation is actually worth considering. And we don't have any of the studies in America that you have in Europe, you have in India, you have elsewhere with all that good data that I showed you. So a few years ago, the question was brought to FASMBS about this operation, and they have a process in place that starts off with the Clinical Issues Committee, which does a literature search, takes out the best studies, and basically it's a meta-analysis. And they found that there were about 38,000 patients in the literature and 69 publications. There were 4 randomized controlled trials, but they tended to be very small number of patients. Most of it was retrospective case series and chart reviews and meta-analyses. But the bottom line was they actually had good things to say about the operation. They acknowledged the short OR time, the low complication rates, and the excellent results, but they still had the concerns of the bile and the nutritional issues. So their conclusion in 2018 was that there wasn't enough data to support this operation, and therefore the operation was not going to get the blessing of FASMBS, which meant not the blessing of health insurance or patients in the community wanting surgery. But this process is a living process. It's not a one and done. This was the same story with the sleeve gastrectomy. The first time it went through this process, it was considered investigational. Several years later, when the data became richer, it was brought up again, and then at that point, it was accepted as an operation for bariatric surgery. Now, I don't want to go back and talk about the cancer thing again, but the bile reflux numbers are actually around the world quite low. What I did was I took out a bunch of these papers and I looked to see what did they quote their bile reflux problem to be, and as you can see, the numbers are quite low. Now, that didn't necessarily mean that this was all bile in the stomach versus esophagus, but I'm impressed that the numbers are low enough. I'm very comfortable with those numbers, and I'd be very comfortable doing that operation and telling patients, you know, there is a small risk of bile reflux. It's somewhere between 0.3 and 4%. And you know, if you were to get bile reflux, we can address it. And when you look in the literature, the number of cases of actual cancer of either the esophagus or stomach after bariatric surgery is quite few. This report by Scozzari, there were only 33 patients who developed cancer after bariatric surgery. In some cases, the diagnosis was made very shortly after surgery, which would make me suspicious the cancer was there when they had the bariatric operation, particularly since not all these patients were endoscoped. In fact, most of them were not endoscoped preoperatively. And the cancers that you see are a mixed bag. We had it with VBG, we had it with Roux-Y, with bands, some in the esophagus, some in the stomach. And again, if you're only 2 months out from your bariatric operation, you weren't developing cancer because of bile refluxing after surgery. That cancer was there before the bariatric operation happened. So what do we need to go across the finish line here with this in the United States? Do we need a miracle? I'm not sure we need Moses to part the Red Sea, but there are steps that we can and should take. Number one, we do need to get U.S. data, good data from the U.S. That may require industry to be involved because someone has to pay for it since insurance won't cover it. We need a U.S. champion. We need somebody in the United States who's got a good reputation to be the leader and to push this very, very hard, because that's how you get things done. When it came to the sleeve, you may remember it was Phil Shower, and he pushed it almost single-handedly across the finish line, and that's what we need. We need patients to partner with us, to pressure the government, the health insurance industry, and the health insurance providers to say this needs to be a covered operation. It's as good, it's no worse than the Roux gastric bypass. Why can't this one be covered equally? And getting patients involved might mean getting the Obesity Advocacy Coalition involved. This is a lobbying group that is made up of patients and bariatric patients and supports bariatric patient issues. And getting their voice and their muscle involved would be very helpful. But the bottom line is that all roads have to go through the FASMBS. And that's where we have to get the U.S. champion on board, surgeons to back this, U.S. data, industry support, and patient demand to get it going. Now, the FASMBS has a new pathway for endorsement, and I've put it here. It's an arduous process, but it's meant to protect the patients from bad operations. So first off, a member of the society has to go forward to the FASMBS and to ask that the process be put in place for whatever the procedure is. The application then goes to the executive committee of the executive council, and they vote on it, and it has to be 75% in favor or greater. It then goes to the clinical issues committee, where it has that meta-analysis process underway, and their decision then goes back to the executive council for another vote. If that vote is over 75% favorable, the application then goes to the membership at large, and they're asked to vote on it. And if they vote in favor, and then the Executive Council votes in favor, that operation now becomes endorsed by the ASMBS. That's the process, and that's what we have to do. So in conclusion, both political issues and the lack of good US data have prevented the one anastomosis bypass from being accepted by the ASMBS and everybody else. International data is great, but the data is better in the would be better coming from the United States if we're trying to get approval in the United States. And the one anastomosis bypass is really just another variant of the gastric bypass procedure and should not be held to different standards. And that's my opinion as well. Once again, I want to thank everybody for allowing me to speak today, and happy to answer any questions. Thank you again.
Turn it over to Arun and Patrick. Any questions?
Scott, that was really a very nice lecture, and we got to know so much more about the background of the MGB-OAGB in the US. My question to you is that you mentioned you do MGB-OAGB as a revisional procedure. Now, do you actually avoid doing it as a primary procedure? Because personally,
if I try to do it as a primary procedure, I can't get it paid for.
Okay, so as a revision procedure, it is paid for, but as a primary,
yeah, there's more liberty in the operating room on a revisional procedure to say, you know, it looks like if I bring a roux up, it may be a little bit tight. I think I need to put a loop up, or I can't do the roux. You know, you can stretch it a little bit, but revisional surgery, you're given more of liberty to innovate. So that's how I was able to do it. But it just won't be covered by insurance.
Okay. So the reason I was asking that question is that mine and many of our Indian surgeons' experience has been that as a primary procedure, it works very well. But as a revisional procedure, it does not work as well as it does as a primary. Saying, you know, to qualify that, say somebody with a BMI of 50 as a primary, he'll lose more weight than a regained after sleeve would do from a sleeve to MGB-OAGB. But I guess that's true for all revisional procedures.
Yeah, I would agree with you. We looked at bands, the sleeve conversions in one stage versus two stages. And when you took a band off and then converted to a sleeve, they never did as well as the group that just had the sleeve. So yeah, I think the literature supports that as well.
So when you revise the sleeve to MGB-OAGB, do you re-sleeve the sleeve also in case it's big, or do you just do the anastomosis as Routledge advises?
If it was very large, I would re-sleeve it. If it was mildly enlarged, I'd leave it alone.
Thank you.
In your opinions, what will be the focus of the next 5 years in the US? You will be able to start the anastomosis MGB in the US, you think, in 5 years?
Sorry, I'm getting an echo, Patrick. I can't hear you well.
Do you think that you will be able to start this procedure officially in the US in the 5 years?
It would be nice if we could start it sooner than that, like right away. But once again, you need a champion, somebody really motivated. And I've spoken to Medtronic. I haven't spoken to J&J. Trying to get Medtronic to fund a trial and have not been successful thus far.
Okay.
I've also, by the way, approached all the insurance companies in my area, and they barely would speak to me.
Other questions?
Okay.
That's fine.
Okay. So if you're done, okay. If you're done,
Let me do a comment, Winnie, please. Just a very brief comment to Scott. Okay?
Have you managed to control the takeover?
Good to see you. Also, Arun. Nice to see you again.
Nice to see you too. Nice to see you.
Scott, that's difficult to understand the policy of United States. because if they are talking about malnutrition, they should go to biliopancreatic diversion or duodenal switch or procedures like this. That these procedures are much more implicating malnutrition than one anastomosis gastric bypass. And if we go to the story of the reflux, we should refer to sleeve gastrectomy. So it looks like the law is just for one procedure and not for the others. It's not convincing me.
I agree with you, and in fact, duodenal switch is an approved operation in the United States, and the SADI is also endorsed by ASMBS. So this one operation is ruled out, and again, you have to think of the politics playing a role in it.
Okay. Let's go on to the next session. Willie.
Okay. Thank you, Dr. Scott Shikora, for such an insightful presentation.
Excuse me, Winnie. Himanshu, mute everybody, please.
Thank you, Dr. Scott Shikora, for such an insightful presentation. Now let me invite Dr. Almino Ramos and Dr. Scott Shikora for moderating the live surgery session on one anastomosis gastric bypass from the operating room.
So let's see Dr. Bhandari doing what he loves to do, bariatric surgery.
So we have with us Dr. Shashank Trivedi, our fellow in the department, who will be introducing you to the particulars of the patient. Dr. Shashank.
Thank you. Good evening, everyone. Today we have a 58-year-old male with a BMI of 52.4. He is non-veg by diet and has no addictions. He is also a patient of OSSI and O.A.E. In the blood profile, the albumin is 4.3 with a total protein of 7.7 and HbA1c is 8.5. The patient is negative for HbA1c, HIV and COVID-19. The sonography show grade 1 fatty liver.
Thank you, Dr. Shashank. So now we'll be going to directly live to Dr. Mohit Bhandari, who will be doing an endoscopy and then followed by the surgery. Dr. Bhandari.
Okay, so good evening, everybody. I hope you can see me and you can hear me as well. So as we know that at our center, we first
adjust your microphone.
Okay, I'll adjust it. Can you hear me louder now?
Yeah, but there's a coarseness in it.
Okay, now? Is that okay?
A little better.
Better?
Good.
Okay, so now is it okay?
Go ahead.
Yeah, so this is the esophagus, and we always perform the intraoperative endoscopy, and that's something different as to what we do from other centers, because most surgeons will do this endoscopy before the procedure, but we do it on table, and we take the consent to change the procedure if we have some untoward finding which does not make the patient fit for that procedure. So this is the Z line, as we can see, and I don't see esophagitis here. This is the stomach. I enter inside. The gastric folds look normal. I can say there is very mild gastritis here. This is the pylorus, and I just have to wait. So pylorus gives me the egress automatically. So you can see I'm inside into the first part of the duodenum. The bile is pouring out, and I can go inside a little bit more. And while I go inside, I make sure that I see if there is any duodenal ulcer, because in future we may not get an access to this particular part of the small bowel. So most of this endoscopy surveillance is done while I am pulling my scope back. So I slowly pull my scope back and I see that there is no duodenal ulcer. Everything looks okay. There is not even any duodenal erosion here. I still keep on pulling my scope back, back, and now I have come inside. This is the nice pylorus, the view of pylorus you can see. Now we can retroflex this particular scope to see if there is any hiatus hernia. Very nice looking hiatus. I don't see any gap or any problem here. I can go back and see the stomach again, looks good. Not even, I would say very mild gastritis, but this does not bother me. This is the area of the fundus. I'm going to suck a little bit of fluid here, although this can be done in a much better way by the anesthetist by using a gastric calibration tube. But I'll still make his job easier. I'll suck all this fluid. Imagine we keep the patient's nil by mouth. How much amount of fluid can enter inside the fundus? And
Mohit,
yes.
Mohit, this is the first endoscopy of the patient, or you have a previous one?
No, this is the first endoscopy. This is live. This is live. So that's what I'm saying. We don't do.
And the patient right now is under general anesthesia.
Yes, yes. The patient is under general anesthesia. We don't do endoscopies like before the surgery. All we do is only on the table, only during the surgical procedure. So that's very different from our center. So, which means, Almino, we have to take a blanket consent if we want to change the procedure. Like here, we do not find anything which precludes this procedure. So now I'll demonstrate my port position. So we establish the pneumoperitoneum through this optical port by a long Varus needle. So can you give me the Varus needle? So I use a pretty long Varus needle, and this is the one I've been using for a long period now. And this Varus needle is used to create a pneumoperitoneum. My optical port is around 2 finger breadth above the umbilicus. I have another port in line with the optical port in the mid-clavicular line on the left side, which is my 12 mm port. I have another port, another 12 mm port, again in the mid-clavicular line on the right side. And I have two 5 mm ports, both in the anterior axillary line on the left and the right subcostal area. So these are the ports I'm going to work with. I've already inserted the optical port. We have to check the liver. I hope we do not find a cirrhotic liver inside. So we check for the liver. Liver looks good. Liver looks fine. Can you give me, I cannot do a 3D without the specs. So we are using a 3D scope here by Karl Storz. I need to wear some specs to see the 3D. And so as you can see, that the liver looks good. We don't have any problems with the liver. Usually in such cases, if we have issues which surround the liver, we might have to change the procedure again. So although we do ultrasound, but in most cases, I would say that a direct visualization of the liver gives a more better picture. I have my ports inside, and once the ports are in, we're gonna do the important steps which are required. The first step would be to first create a space for us so that we can create a space into the lesser sac of the stomach, and then we start to make the pouch. So as Professor Fobi said, this is sort of a short procedure. In most cases, we should not have a problem. I want to introduce you to something very special which we have at our center. This is our own device, liver retractor. I don't use all those fancy Nathanson's liver retractor mostly. So we have this, as you can see, this is our liver retractor which we use, and I'm going to insert it. It's you can even retract heavy livers with it, and the beauty is that it does not. It's like less than 3 mm. So this is a good liver. I think God has been considerate. Usually my experience with live workshops have been bad livers, and they are mostly tedious when I'm doing a gastric bypass. So this liver retractor which we use works well. Now at this stage I would call my anesthetist. So I've been assisted by a great team. Dr. Dikshit is our anesthetist. He's been with me last 15 years now, and Abhishek is assisting me. So Abhishek has again been, these are last 15 years, both my team, my anesthetist, my assistant, and we have done over 13,000 bariatric procedures together. So what Dr. Dikshit is now trying to do is evacuate the stomach. And as you can see that there is a lot of fluid in the fundal part of the stomach. So that's what he's trying to evacuate. Now, what is the first step in the mini gastric bypass? So even before I start anything, I'm gonna just make the landmarks clear to you. So this is, here is the pylorus. So this is the pylorus here. This here is the incisura angularis. Here is the CBD. This is the gallbladder. This is the CBD here. So what I'm gonna do is, just at the level of the, below the level of the incisura, I'm gonna make a plane and enter inside the lesser sac of the stomach. Now the vessels here are a little more, the vascularity is a little more than what we expect because we are close to the pylorus. So what I usually do is I use a energy source which is more hemostatic. So my settings of the energy source would be more hemostatic in nature rather than the cutting in nature. And at most times we are able to manage. We would always request the anesthetist to keep the blood pressure a little low. Low means for me is around 130 to 140 mm of Hg. That's fine. Because if we keep it very low, as Professor Fobi explained, the most common complication in our 4,000 cases which we did at Mohawk we had was the bleed from the staple line, and that's most commonly which happens with the mini gastric bypass. So I often use a sealer here when the blood pressure is very high to just seal the large vessels which are present. So this helps us to take care of these vessels which may bleed while we are firing the first stapler. So as you can see, this is the area of the stomach which we want to make clear. Now you see a large pat of fat here. So I'm not going to fire the stapler until I see the posterior wall of the stomach very clearly. So now I can see this is the posterior wall of the stomach. Although there are some additions, but I can at least fire my first cartridge at this particular stage. So give me the first stapler. So the first cartridge which we fire here is a gold, and I'm using the gripping surface technology reload by J&J. So this is the gold stapler, and I start to fire my first horizontal staple 2.5 centimeters below the incisura angularis, and also making sure that I do not obstruct the complete lumen so that I drain the remnant. So you can see that this space remains here, which we will never obstruct. We are concerned about the drainage of the lumen here. So that's what I would do. Now at this stage, you can see that by firing the first cartridge, I made my job easier because now I can dissect the adhesions which are there posteriorly. I have seen some surgeons, they keep on dissecting and they make the job for themselves much more difficult, because sometimes when you fire the first load, you can obviously get a good amount of egress inside the lesser sac of the stomach. Now, as you can see, the second cartridge or the second load is a blue instead of a gold. So the reason why I am doing that is that the tissue close to the lesser curvature here, close to the pylorus, is a little thicker, and that's why I use a gold here. Whereas the tissue which is there close to the greater curvature of the stomach is not that thick, so we can still do with a blue load. If I would be using a Covidian, I would have been using a purple all throughout. Sometimes I use a black for the first cartridge which we fire. Now at this stage we can come in with the blue load, and we can ask the anesthetist to bring in the bougie. Can you bring in the bougie, please? So that's the bougie in place, and now I can fire. So once the bougie is there in place, I'm actually very comfortable, and that can be done after we have done the stapling with the 2 reloads, because that is a stage when we are easily able to manipulate the bougie inside the gastric pouch. Now, it's simple. You can go up continuously and create this space. The only thing which is important at this stage is to keep a note that we are keeping a good amount of remnant to drain. And that's the simplicity of a one anastomosis, that you can keep on firing the stapler. Now the bougie size I'm using here is a 38 French, although I measure the breadth and the length of my pouch once I have made it, just to make sure that I'm not making a very, very short pouch. We are not very close to the bougie, as you can see. So there are two ways of firing this. I've seen surgeons going as close. I would not go that close. I remain here. I would say the bougie would be, I leave some space at the 38 French bougie while I'm doing my stapling for a mini bypass. So you can see now this is a different technique which most surgeons would not do. I do not dissect close to the GE junction there. So I have seen the MGB surgeons doing a lot of dissection there close to the GE junction, specifically those who do revision. Now what I do is I do a dissection here with my cartridge here like that, little bit of dissection, and then I go inside. And then what we can do is, without dissecting too much, you can see that I have come out of that area. So what I do is, I do a retrogastric dissection, but not the dissection at the GE junction. So I'll fire this. I hope we do not require one more cartridge, but okay, we'll take one more. Let's take one more. So you can see that I've completely separated the pouch from the remnant, but we'll take one more cartridge just to separate the remnant completely. We don't want any chances of any fistula. So that's the area there. Mostly these are just the additions. I don't think there is a gastric pouch there. I'm going to go up, pull this momentum down, and just going to demonstrate you that I have completely, so that's the area which I need to separate it out. And that's done. So this is the pouch being completely separated from the remnant. It's nice draining remnant seen. I'm not going to do too much of hemostasis here at this stage because our blood pressure is pretty high, which our anesthetist has kept. He's trying to bring down the blood pressure. So I'm just going to put a gauze there and just wait for this bleeding to subside. In the meantime, I'm going to do a little bit of dissection here posterior to the gastric pouch. This dissection. So this pad of fat is something which is very important technically. I would not fire the stapler on this pad of fat. I dissect it a little. I've seen some surgeons firing it. I usually would not recommend it. We have seen gross level of hematomas developing there. We have seen problems in terms of having a lot of bleeding sometimes. So it's a very thick pad of fat there. So I'm just very cautiously going to dissect it, take care of the hemostasis there. And as you can see, it's easy to remove that fat. It's not that difficult to remove that fat. Just takes a little bit more time when it is thicker. The same thing for a gastric bypass. If we have a lot of fat over the pouch, we try and remove that fat because fat obliterates the anatomy. And once that anatomy is obliterated, we are not able to recognize major landmarks. So that's what I'm going to do. So I'm going to dissect this pad of fat until at least 6 centimeters from the tip of my pouch, because that's the area I'm going to do some suturing, some stapling. So it's best to dissect it until around 6 centimeters. You can go a little bit up to remove this pad of fat so that the anatomy is more clearer. Okay, now it looks good. So this is the complete dissection. This is my bougie. This is the tip of my pouch. I'm going to make a gastrotomy now. And the anesthetist would be kind enough to push the bougie. So you can see that that's the blue of the bougie, which I can see. It's a nice gastrotomy being made. So that's it. Now I can go and do the infracolic part of the procedure. So this is a large amount of omentum which we have here. I haven't divided omentum in my last 4,000 cases in more than 2 occasions. But sometimes we do need to divide this omentum if you have a lot of pressure there or the adhesions are there. So for example, in this particular case, I could see that there are certain adhesions here, which can make the path for us a little difficult. So what I'm going to do is, I'm going to just do a little bit of scoring of this particular omentum here, just to avoid the pressure. This patient is a BMI around 54. We don't want any pressure on the loop. So this is a trick. I just take this omentum here and just a bit of division so that I do not put my bowel under a lot of pressure to do the anastomosis. So, and we're not going to divide like we do it in a gastric bypass. Just take a little bit of it here, because that's the area where I feel there is some pressure and it's stuck to the abdominal wall. So just like that, and I can see now that I'm reaching to the base of the transverse colon. So it's good. And now I can see very nicely the transverse colon can be rolled upside down like that, so that I can have a good look at the area of the ligament of Treitz or the inferior mesenteric vein, which is our landmark. Now you see, this is a tough landmark usually to delineate. And as you can see, I am trying to get the pad of fat away from my site. So give me a grasper now. Can you take the patient a little more supine? Okay, so this is the area. Now I would demonstrate you the ligament of Treitz. So that's the ligament. Now it can be seen. We cannot see the inferior mesenteric vein. It's very fat laden, but yeah, now you can see even the inferior mesenteric vein there. It's nicely visualized. That's the ligament of Treitz. Now I'm going to use to count this. So the way we count here is very simple. We have markings done here. So you can see this is a 10 centimeter mark, and I have that on both my graspers. So that was what I did, was around 10, and this is 20, 30, 40, 50, 60, 70, 80, 90, 100, 110, 120, 130, 140, 150, 160. I'll just check if there is a bleeding until 160. I always check if there is a bleeding that I haven't made an enterotomy. So here is a serocell damage, and I have counted here till 160. So I'm just going to repair it. I'll take a stitch here. I'll just count 180, mark my limb. So this is 170 and this is 180. So I'm going to mark here my limb, and before I do the anastomosis, I will repair that serocell tear which happened while counting. So this is, give me a clip. So I'll mark the limb first. So the marking is done in a way that we mark two clips here, and which is the distal. So the distal is the 2, and the proximal is the 1. So we are not confused as far as the mesentery is concerned. Give me a suture. So this is what we have to be cautious about. I see that there is a serocell damage there. I'm not going to take the risk. I'll just take a stitch before I do the anastomosis. We have already counted to 180 centimeters. I'm going to take that and take a stitch so that I do not have any doubt in my mind about the integrity of this bowel.
2 points would like to make at this point. There are people who advocate complete counting of the small bowel routinely. As you can see, there is a high probability of bowel damage when you count the bowel. So the less you do in counting the bowel is an advantage. So that is something you can learn. I'm glad this occurred so you can see it, because when we talk about it, people just assume you can count the bowel with impunity. The second thing which Dr. Bhandari did not mention, which many people are concerned, when people talk about intraoperative endoscopy, the first question they worry about is in doing a bypass, whether it's a mini gastric bypass or a regular gastric bypass, they worry about operating on insufflated small bowel. As you can see here, he did the endoscopy and the small bowel is not insufflated, and we have not had any problems doing the anastomosis in a gastric bypass or a single anastomosis gastric bypass, MGB, and the bowel is just as normal as in the regular bowel. So intraoperative endoscopy does not cause insufflation. Obviously, if somebody is doing endoscopy for the first time and takes an extraordinary length of time, the bowel might be insufflated. But Dr. Bhandari uses CO2, and by the time you finish the proximal part of the operation, the CO2 is reabsorbed, and so very rarely do you have to deal with insufflated bowel if you use CO2. Go ahead, sir.
Yeah, so I think there are two ways of avoiding the bowel gas. The first is the most part surgeons would do is they would keep on pushing air while they are doing the surveillance of the duodenum, which I usually avoid. I put a minimal amount of air inside the duodenum, and while I come back, I usually suck the entire air. So I think this is a repair which we have done. I am now not concerned about anything. I can see on the other side as well, and that's fine. So always we should make sure that we see both mesenteric and the anti-mesenteric side while we do this repair, and I think I'm okay with this. It's fine. So now we can go ahead and start to do the anastomosis. We can again do a check. The best way to check if we have done a serosal damage or a through and through damage is by using the method that you have a bleed, and usually that bleed is a fresh bleed which is happening while we are doing. Now, I would just like to demonstrate where we did the marking. So you can see that this was the proximal and this was the distal. So the distal had two markings. This was exactly at 180 centimeters and this was around 170 centimeters. I'm going to come here a little distally, distal to these clips, a little more here, and I'm going to make a enterotomy just before we do this anastomosis.
Mohit, we have a bit of echo in the sound. So just to have clear, this is 150 or 2 meters?
No, this is 180.
2.
Can you hear me?
180.
No? 180.
Okay,
Yes.
I'll can anybody help me with the sound, please? Can you hear me now, Almino?
Yes, yes.
This is 180 centimeters.
Dr. Fobi did, I think, a very important comment, because I'm sure, Mo, if we start to recommend to check out the bowel in every procedure, this will double the mortality of bariatric surgery in a week. So we have to be very cautious about that.
Absolutely.
So fully stapled, Mohit.
Hello. Yeah. So this was a blue reload which I used, and we did an anastomosis of complete 6 centimeters, as you can see. I'm going to measure it for you once I complete the procedure. And the limb length of the biliopancreatic limb which I took was around 180 centimeters. So we used the grasper. So you can see this was the grasper which I used to measure. There can be an error of around 10%, which is acceptable. As far as the bowel counting is concerned, we never count the entire length of the bowel. At most times I have just counted around 200 centimeters of the bowel, and I agree that our incidence of having such a damage of the bowel, the serosal or the mucosal, is very less because we do not count the entire length of the bowel. this trauma or the chances of damage is much more when we are operating upon a super obese patient. So as you can see here, there are a lot of omental adhesions, so tackling the bowel is a little more difficult than the normal cases. So that was the caudal stitch, the stay stitch which we took. Now I'm going to come to the Kifilad part of it, and I'm going to suture the Kifilad end. So this caudal end which I sutured, as you can see now here, that I have absolutely made sure that there is no leak or no gap there. So this is the caudal end of my anastomosis, and now I'm going to come to the Kifilad end. So we're going to tighten it up, and then we come to the Kifilad part of the anastomosis, which is this. So you can see it's here, and I'm going to start from here a little above, so that I'm sure that I'm at least 2 centimeters away from the gastrotomy.
Mohit, I want to get back to the endoscopy. If you had performed the endoscopy on this patient and it came and you saw Barrett's esophagus, what operation would you then do for this patient?
If I have a very high grade of Barrett's, which is like grade 4 or grade 5, usually I would have gone for an RF ablation and then called the patient back. But if it was grade 1 and 2, I would have gone for a Roux-en-Y gastric bypass and not a mini gastric bypass. And my reasons for doing that would be that we know that bile reflex esophagitis can complicate a Barrett's esophagus, and that we have seen in the past in one of my patients. And also the data is suggestive that the bile reflux gastritis in an incompetent LES can simply deteriorate the Barrett's and convert it into a malignancy. So I would not recommend doing a mini gastric bypass or a sleeve in such cases. I would definitely go, and in very, very high stage Barrett's would go for an RF. And if there are stage 1 and 2, the best choice would be to do a gastric bypass and then follow up the patient.
Thank you.
The other thing we do is anytime we have ALA classified esophagitis greater than grade A, we do a biopsy also. That way we can monitor it subsequently.
Irrespective, biopsies have to be done. But I think as far as the procedure is concerned, we mostly recommend a gastric bypass. And if we find Barrett's, we would definitely find defective lower esophageal sphincter in most of those cases on the manometric studies and the pH studies. So irrespective, we have to confirm them. We have to take a biopsy, and both these things, as Dr. Fobi said, but the choice of the procedure will have to be a gastric bypass and low grades of Barrett's esophagus. So that's the end point of our anastomosis. We started from the caudal end with the Kifilad and we stopped here. So I took the entire layer here. Now what I'm going to do is I'm going to come in with an endoscope to see if what sort of an anastomosis I have done. So let me bring in the endoscope. In the meantime, my assistant can block the two ends, the afferent and the efferent ends of the anastomosis by a stapler, which is fired. We had one serosal tear where I could see the tear going a little deep, so we repaired it. I am satisfied with that repair. And then we came up and we did the anastomosis. Now this is the efferent end, which my assistant is holding with a grasper. So we're going to block the efferent end with the grasper, and then we can use a fired cartridge. We just need to hold it with soft this thing. Now the internal anatomy can be visualized. My purpose of doing this is not to check the leak. We usually do not do a leak test, but the purpose is to demonstrate you the internal anatomy and plus to check if there is any bleeding inside. The afferent end would be blocked just by a grasper, and as you can see, he has blocked it, so very minimal amount of air could go in distal to this. So now I would enter inside with the scope. So as you can see, We have minimal amount of blood in the esophagus, which is natural. And this I have found in most cases, even in sleeves also. When we have some minimal amount of blood, this is the G junction, as you can see, the Z line. Now, the Z line can be visualized in a much better way here. This is the Z line, which I see. This is the pouch. As you can see, this is the staple line here. And I'm going to go inside very slowly. We come here close to the anastomosis. So that there is the anastomosis. And now I can see both the loops of the bowel. So this is the anastomosis here. Now I can see here both the afferent and the efferent. So this passage which is blocked here, I can go a little bit inside. So this is one of the loops, which is the efferent loop, and you can see that's blocked. You can see the same view here in the PIP, and there is the afferent loop. So they're down at the 6 o'clock position here. This is the afferent loop, which we can see. So both the loops, because they are blocked, I'm not going to go and create too much of pressure onto them. But now once we pull our scope back here, I can see this anastomosis here. It is nice. We have a wide one here. When I pull my scope back, this is here the staple line, which we can follow back throughout the entire length. We had some bleeding, which was outside, but I don't see a lot of bleeding inside. There's no active oozing inside. As far as my scopy is concerned, I am easily coming back here. I have a little amount of blood here, but that's all clotted. So this is again the Z line. I'm going to do a little bit of suction inside so that I can deflate this entire part. And now I can come back into the esophagus and suck all that fluid which is there inside. So that marks the end of the procedure. Now I will measure the length of the pouch and the length of the anastomosis and the breadth of the pouch. So give me a, can you come in with the gastric calibration tube? So now we will use the endo stitch on a stretched. So why I want a GCT? Because I want the endo stitch to measure the length on a stretched tube rather than on a completely flexed tube. A stretched tube on a gastric calibration tube can measure it in a much better way, and that standardizes, because every time we measure it, we put a tube across into the anastomosis. As you can see, we are here. Okay, we are distal. So now this particular area is the G junction, and on the stretched tube, I see that my anastomosis is exactly at 19 centimeters, 18.5. So this is the area where my anastomosis is there. I can straighten it up for all of you. So this is the length of my pouch is around, I would say, 18 centimeters. Now, what is the breadth of my pouch? So can you bring in a tape so I can measure the breadth? Yeah. So I can take this and I can measure the breadth of my pouch. So this is the tube in. Take out the tube, please. So we can just, now we can do it more easily. So what I can do is I can hold this end here, and this is the end of my anastomosis. So it's around 5 centimeters, as you can see, the length of my anastomosis. The breadth of my pouch, can you bring in a tape so I can measure the breadth? So
Yeah.
okay, so that's on a 38 French bougie, and if we can see, that's around 2.5 centimeters. So I would say more than 2.5, 2.8 centimeters, and it's uniform everywhere. You can see we have been keeping the same length. So on an average, the length would be around 2.5 centimeters. So the length, the breadth. So the length of the pouch, 17.5, breadth of the pouch, 2.5 to 3 centimeters, the anastomosis of size 5 centimeters, the length of the BP limb 180 centimeters. If there are any questions, I would be more than happy to answer.
Almino, go ahead. Go, Scott.
Yes, I think that was a very nice procedure, as we should do when we are doing one anastomosis gastric bypass, narrow and long tube at minimum to 15 or 18 centimeters. The longest will be better. A big anastomosis, I think the use of endoscopy perioperatively can help a lot. So I think that I'm happy with the result of the procedure. It's a nice procedure.
Usually, are you repairing a hiatus hernia when you find one?
Can you repeat your question, please?
You repair hiatal hernia if you find one.
No, if I find a hiatal hernia, I would do a gastric bypass. We don't do, if you have a large hiatus or something which needs to be repaired, I would either not repair the hernia and directly do a gastric bypass, or I would repair the hernia if it's large and do a gastric bypass. We are not performing mini gastric bypass. We don't have experience to perform mini gastric bypasses with hiatus hernia at our center, because I think we made this protocol long back, even before Dr. Fobi came in, that we are not going to do patients with hiatus hernia, we don't expose them to mini bypass.
Mohit, this is Mitch Roslin. Congratulations on a beautiful procedure. My question is for both you and Dr. Fobi is that you seem to indicate that your procedure of preference for patients who have liver disease is not a one anastomosis gastric bypass, but your procedure of preference for people with severe diabetes is a one anastomosis gastric bypass. In my experience, people with profound insulin resistance usually have very fatty livers, yet you listed that as one of the relative contraindications. So how do you balance those two factors? Because I would say that people with the most insulin resistance, and usually people who are on insulin, have the highest percentage of fatty livers, yet, and you say that it's preferential one anastomosis gastric bypass. So what level of fatty liver will you not do a one anastomosis gastric bypass? And is that because you're so concerned about protein malnutrition leading to liver failure?
Yes, so first of all, it's a very good question. I think we have to have a trade-off between giving a good resolution of diabetes versus doing it on a bad liver. So fatty liver 3, 4, and 5 and higher grades of NAFL with established cirrhosis won't get a mini gastric bypass. Fatty liver 1 and 2 with severe diabetes, just mini gastric bypass. My procedure of choice, or our procedure of choice for patients with diabetes with a higher grade of fatty livers would be a simple gastric bypass, because that's more restrictive. We won't give a mini gastric bypass in such cases. So the strategy to patients with very severe diabetes but requiring a bypass would be a banded gastric bypass or a conventional gastric bypass and higher grades of fatty liver and cirrhosis instead of mini gastric bypass, because we are concerned that these patients might deteriorate their cirrhosis.
What is your favorite procedure after sleeve failure today? Depending on the hiatus, depending on the diabetes, depending on the liver?
Yes, so our favorite procedure has been converting a sleeve to a banded gastric bypass. We have good amount of data on that. Initially, before 2017, we were revising these failed sleeves to one anastomosis gastric bypass, but my results were very terrible. I never had weight loss. Good amount of weight loss to say, which is substantial enough to justify. So then we started converting these sleeves into a banded gastric bypass. And in severely diabetic patients, our BP limb was 150 centimeters to 180 centimeters. So we started adding a longer BP limb with a banded gastric bypass as a conversion of sleeve for sleeve failures. For diabetics, our limb lengths were a little high, say around 180 centimeters. For super obese patients, our limb lengths were high, say around 180 centimeters, but all other patients would get 150 centimeters of a BP limb with a banded gastric bypass from conversion to a failed sleeve, and that's what is our preferred procedure. We have stopped doing mini gastric bypasses or SADIs or other malabsorptive procedures, two malabsorptive procedures after sleeve failures at our center. Considering poor results, or if we do a lot of malabsorption with a common channel less than 300 centimeters, we had a lot of malabsorption, which was causing liver failures and more than 100% excess weight loss and other complications. So at this point of time, a banded gastric bypass is our preferred procedure.
Okay. Question, Scott?
I'm good. I think he explained things quite well.
Let me just go down. Almino, I see you do a mini gastric bypass. You've published some material on diabetic patients.
Yes, we are working in our public hospital with a study in this kind of procedure. We are comparing the one anastomosis gastric bypass and the one anastomosis duodenal switch with the regular procedure we have right now. That's gastric bypass and sleeve. And really, we are happy with all the procedures. I think that we need a better alternative for super obese patients. That's the reason we are studying. I'm happy with the results of sleeve and gastric bypass for regular obesity, but for super obesity, I think what we are reaching with gastric bypass and sleeve gastrectomy is not enough. So that's the reason we are studying new procedures. But sometimes it's difficult to interpret medical literature. So let me put you some concerning I have. If we go to the one anastomosis gastric bypass, mainly the Hispanic version that recommends 60% as biliopancreatic and 40% of alimentary of common limb, and we compare with one anastomosis duodenal switch, the regular one, we will have about 250 to 280 in common limb and about 350 and 4 in the biliopancreatic. They are very similar. They are very similar. And there is a huge difference in between the techniques that we have. In the middle of the duodenal switch, we have the pylorus. So I think that someone in the literature is not telling exactly the truth, because we are with very similar procedures, but with a huge difference in terms of technique. I'm talking about the similar results. So I think that this is incompatible. We should study more these procedures to understand better, to have a final conclusion.
I think your point is well made. That is why having a registry and putting data in the registry is important. And as Scott says, that is the advantage of getting the American institutions on board, because with MESQUIT, everything is entered into a database, and then it can be retrieved easily, and we can see the differences. But until that time, we're left with opinions and data that is questionable. And you're right. Like I said, I looked at 3 cases this weekend, and I didn't know whether the pylorus was working or not. And then I see the difference in the results or the similarity, and I question it. But it's all data, data, data. Patrick, do you think the problem we had with the French study was because they did the MGB in everybody irrespective and not selectively?
I think so. This is one of the reasons. The second reason, it was a randomized clinical trial with non-inferiority, and they compared one anastomosis gastric bypass at 200 centimeter with 1Y, and 1Y was, I think, 50 centimeter of biliopancreatic limb and 100 of alimentary limb. So first question, is it comparable? I'm not sure. Second question, the conclusion, the first conclusion, where that in terms of weight loss, we had almost the same result. In terms of comorbidity, almost the same, even if one anastomosis gastric bypass did better. But as you can imagine, we have more complication like malabsorption in the one anastomosis gastric bypass group. So the conclusion was it's similar, almost similar, no statistic difference, but possibly more complication. And from that, the French Society of Obesity and then our Ministry of Health decide to suspend the mini bypass, because why allowing to do mini bypass if you have the same results with more complication? But there is a lot of bias, I think, possibly in the study.
I
Thank
think where I would disagree with Mohit is I would measure the entire small bowel on every case, because we've seen such variation. You can't possibly get the same results for weight loss from malabsorption when somebody only has 300 or 350 centimeters of total small bowel versus the next guy who may have 1,100 millimeters of small bowel, centimeters of small bowel, sorry. It can't be the same result.
What we realized was that out of what 4,000 cases we did, I think it makes sense to count the entire length of the bowel if we are going to bypass more than 250 centimeters. If we measure the entire length of bowel in all the cases where our anastomosis would be around 150 to 180 centimeters of a biliopancreatic limb, it would be too much of an exercise, because that's what we realized. We never had, I think out of, if we talk about 180 centimeters as a BP limb length, I think Dr. Fobi can endorse that we have been doing this 180 centimeters since 2017 now, almost 1,500 cases. Only 2 cases I remember out of those 1,500 where despite taking a 180 centimeters of a limb length, we had to come back because there was a short gut syndrome. What do you say, Dr. Fobi? We never.
Yeah.
So
we had one case where we did 180
one
centimeters.
case I remember. I don't remember the second case even. I was searching through my data. So I would personally say that as far as our data, I cannot claim anything, but what data suggests that when we did 180 centimeters as the highest amount of bypass in a mini bypass with the way we were calculating, in odd 1,500 cases, or maybe 2,000, I would see, but it's more than 1,500 for sure. We had just one case, we had to come back with a short gut syndrome. So I would say, and I would want to know what Dr. Arun Prasad or what Almino thinks, that if we bypass less than 200 centimeters, do we need to count the entire length of the bowel? Having said that, if we are doing a bypass on a super obese patient where we think that we want to give him a lot of weight loss, then I think it makes more sense to start to count from the IC junction and maybe leave a common channel of 250 and give the entire gut length a bypass. But that unfortunately in India can be, both can be too much for the patient and too much of an exercise for the surgeon. I think Dr. Arun Prasad or Almino can comment on that. Dr. Prasad has done quite a bit of mini bypasses, and I know that he does not measure the entire length of the bowel, and I have seen at least 50 more surgeons who have a good substantial amount of MGBs a year, maybe more than 250 MGBs a year, and I haven't seen them measuring the entire length of the bowel because they bypass less than 200 centimeters. For an instance, Kamal Mahavar's unit does not measure the entire length of bowel, and they bypass just 150 as a standard. So
sure. I agree, Mohit. I think these days when the total bypass which we are doing is 200 or less, perhaps it's not required to measure the bowel, because A, you can injure the bowel when you are trying to measure it completely, and B, it adds on to your operative time. But yes, in earlier days, there was a phase when we were doing much longer bypass. I remember we were doing 300 centimeters. And at that time, I think it was essential that we measured the entire bowel length. But if the bypass segment is not that large, perhaps I would not be in favor of measuring the bowel length.
So the data here is not new. I think we all met in Hamburg. I think Dr. Shikora was also there. I think Dr. Fobi was there. As far as I remember, Almino organized that great meeting, and I think there was a consensus that if we are bypassing less than 200 centimeters of gut length, most surgeons, 80% of them says we don't measure. What do you say, Almi?
Mohit, let's go in the thinking that we are checking out the length of the bow.
Okay.
What would be enough as common limb? Arun, what would be enough as common limb for you?
Common limb for an MGB for
Yes.
a mini gastric bypass? I would say a minimum of 300 centimeters.
300?
Yes.
Yep.
Yes. I would go a little beyond that. I would say around 350 centimeters is what myself and Dr. Fobi will discuss the safe length for Indian patients. It's very important also how we measure the limb lengths. I think they should be measured by either a ruling tape or a grasper with the bowel nicely stretched. And we should, even if we damage the bowel, we can repair it.
There is something that is important, I think. We are starting to use the one anastomosis gastric bypass with the idea of having something more powerful than the regular gastric bypass. That's correct.
Yes, absolutely. Yes.
So I think that if we will enshort the biliopancreatic limb, we will decrease the power of the procedure.
Yes. We need a. So I tell you, I got your point. So you see, this procedure is very strong than the gastric bypass, because in the gastric bypass, your food comes in contact with the pouch. It's just a bypass of 80 centimeters. The food immediately comes in contact with the ruling, and the ruling is in. Once it comes in contact with the ruling, all the glucose is absorbed. But here you have neither the bile nor the food comes in contact until 180 centimeters. So the bypass, the conventional Roux-en-Y gastric bypass is a very weak procedure as compared to the mini gastric bypass. So I think even the gut length of 150 centimeters is pretty strong, Almino, as far as I'm concerned. Number one. Number two is, if you see, I don't know the reason, but the entire assembly which we create, the narrow tube, the long tube, and the 180 centimeters limb, it creates anorexia and certain hormonal changes which are beyond restriction and malabsorption, which gives more strength to the procedure. So I think even with 180 centimeters, it's a very strong procedure.
Mohit, Mohit, it's Mitch Roslin. I have a question for you. I was talking to Scott last night, and when I do actually like a SATI, I measure from the terminal ileum. But when I do a gastric bypass, I now invert it, and my biliopancreatic limb is 150 centimeters. When you guys do a gastric bypass, what is your biliopancreatic limb? And isn't that, I think that, traditional bias is that the roux limb was longer than the biliopancreatic limb, but I think as we've learned more, I reverse that. So I generally will have a roux limb of about 75 centimeters and a biliopancreatic limb at 150. And I wonder if you actually look at it from that standpoint, would the results be roughly the same?
Yeah, so you do a fantastic thing, Mish. I think I agree with you. Now, let me tell you what Dr. Fobi taught us. And I think you would agree is that the function of the biliopancreatic limb, as you very rightly said, is the metabolic strength of the procedure. So I absolutely agree that if you do a 150 centimeters of a biliopancreatic limb, it's going to be a very, very strong metabolic procedure. And I think you should do that because you are not putting a band over the pouch like we do. The elementary limb, the function is just to prevent the bile reflux. From the data which we have, any limb length more than 50 centimeters would be good enough to prevent the bile reflux. So let's not focus upon the elementary limb. Let's talk about the BP limb. So I think you are right when you say that you want to make your bypasses more strong and you increase the limb length of your BP limb to 150. And because you do not use a band over your pouch, you can do that. Whereas in India, the most gastric bypasses I perform are the banded gastric bypass, and we treat this operation called as the gastric bypass or the banded gastric bypass primarily as a very restrictive operation. So our limb lengths are just 80 centimeters as a BP limb and 100 centimeters or around 80 to 100 as a elementary limb. And we don't go beyond that until and unless we have very, very severe diabetes in super obese patients. So for instance, we have very severe diabetes in a BMI 52 where a mini gastric bypass is sort of contraindicated. Only those are the cases where we would go ahead and take a BP limb like you do in our series.
Okay. While you're on there, I just asked a question. Arun, you do a lot of robotic surgery. Have you found out that it's advantageous to do robotic mini gastric bypass?
Yes, in a super obese patient, I think when the BMI goes beyond 50 or 55, I find the robot quite useful. At the dissection around the hiatal area, and also the anastomosis which I do an end to side anastomosis, which is a sutured anastomosis, and it's a true end to side, because when we do a stapled anastomosis, whatever you do, it's actually a side to side. So in the super obese, where the instrumentation can be a little difficult, I find the robotic useful.
Okay, I'll turn this over to Winnie to make the closing remarks. We are at exactly 2 hours, 1 hour, 59 minutes. Thank everybody. Winnie, go ahead.
So, thank you, Dr. Fobi. Thank you, everyone. Thank you, Dr. Scott Shikora. Thank you, Dr. Michelin Roslin, Dr. Arun Prasad, Dr. Patrick Noel, Dr. Almino. Thank you for taking out time and being a part of this VBU. I hope you had a great time during the episode, and I hope to see you soon all. Thank you so much.
Okay. We have quite a few questions from the audience, but the time is up. We would respond to the questions appropriately by email or on the VBU website. Again, thank you all. Thank the faculty and thank the people who were in the chat room with us. This is recorded. It will be available on the VBU virtual website, hence, and you can always replay the whole video at your convenience. Thank you very much. We'll see you next week, episode 5, and we'll be talking about the gastric bypass at that time. Is that still the standard? Have a good day. Bye-bye.